But without further ado, I want to introduce Nick, who's also going to introduce some of his co-presenters. Nick is a senior fellow at the Division of Public Behavioral Health and Justice Policy. He's been involved in disseminating evidence-based programs for juvenile justice-involved youth with co-occurring mental health and substance use disorders, and got his MD from Harvard Medical School. And completed his postgraduate training in general child and adolescent psychiatry at the University of California, San Francisco. So we welcome Nick, and also if you haven't had a chance to sign in, please do so and complete an evaluation at the end. And we'll be happy to get you any continuing education hours that you're looking for.
Thank you, Sue. And I'll be introducing Jake Towle and Nicole McManus later in the presentation. They're going to enrich the presentation a lot. And I know that there are a bunch of people in the audience who have great intimacy with the FIT program at a whole bunch of different levels. People that are out there as FIT coaches right now. We've got folks who have been involved in developing the program and supervising and consulting to the program. So I'm humbled by the expertise in the room regarding what I'm going to talk about. And I'll say up front that probably a bunch of what I say will be pretty familiar to those of you who have been working on this program, but I'm still going to try to get back to basics so that everybody is included, and also so that the material is available for people online eventually when this talk goes online. Just really quick before I start, does anybody in the room have a question about the program or about this topic in general that they really hope gets answered during the presentation? And then even as I go through my slides, I'll try to address that or find a time for one of the many experts of various kinds in the room to address the question. No? Anything? Okay. Well, then I'll just jump in. And I'll start with my own background, which some of you know, but certainly not everybody. So, as Sue mentioned, I'm an MD, and there aren't a whole lot of MDs who are talking about intensive psychosocial interventions for justice-involved youth. And so my path here, I think, is instructive, and it's I think it's meaningful for me. It kind of illustrates why I'm doing this work, why I got interested in it. And some folks have sort of heard my story before, but I'll say it again. I'm a child and adolescent psychiatrist, and I've always been very dedicated to community child and adolescent psychiatry, community child and adolescent mental health. And I was working at an agency doing kind of full scope child and adolescent community psychiatry, community mental health, and was seeing just a range of kids from a range of ages who were struggling with very severe and complex problems. Not just their mental health problems, which is theoretically the main focus of a psychiatrist, but very complex psychosocial problems that are connected to their families and neighborhoods of origin, and to social forces even greater than that, and a lot related to discrimination and oppression and lack of opportunity. In my agency job, I felt like I was one of a team of very dedicated people trying to make an impact in these cases, but just feeling like we were just stumbling because we didn't have the resources, both in terms of the time and manpower, human power, excuse me, and also the tools to address the complexity of the problems we were seeing across the age span. And there are lots of different kinds of problems where we felt at a loss, but there's no doubt that one area where we felt particularly frustrated and sometimes really quite hopeless was working with adolescents coming out of incarceration back into the community with mental health and substance abuse problems. I mean, this was a population where it was very, very easy to become hopeless very, very quickly with the resources that we had, and to really feel like, what can we do? What could we possibly do that would have an impact? And there's a temptation as a psychiatrist, and also the agencies encourage this to, because you're a psychiatrist, you can prescribe. So there's this temptation to try to find a medication fix if you can't find something else. And certainly tried to fight that. But even sometimes families and even youth are looking for that, because in many cases, in my opinion, the really intensive, full-scale psychosocial interventions that they need just aren't available, even when they get to an agency, and many of them don't even get to an agency. So because of this frustration with this population and a lot of other populations we were serving, I came to the university on a fellowship that I've been doing for the past year to try to learn more about really impactful psychosocial interventions, the kind of things that actually might really make a difference. And so I'm pretty new to this, and I didn't have expertise in juvenile justice, and I've learned a tremendous amount over the past year. But I'm not an expert. I'm learning, and I'm learning as I go. And so what I'm really going to do today is share some basics about the program, but from the perspective of a learner, not from the perspective of an expert. Luckily, we do have some experts, both expert practitioners on the front lines and expert consultants and supervisors that can help us think some more about this intervention when we reach the limits of my knowledge. But from there, I'll kind of jump in. So family integrated transitions is an intensive psychosocial intervention for youth leaving incarceration. And that is, unfortunately, not a small population, particularly in this country. So this is the big picture context, which I think we all have to think about. Here we go. So this is the rate of juvenile incarceration comparatively in different countries around the world. Most of these are European countries, but there's even South Africa on here. And we could debate the numbers, but the magnitude of difference is just like eye-popping for me. Just the rates at which the United States incarcerates youth compared to the majority of other nations, and certainly developed nations. Well, I won't get stuck on just how troubling it is to see this difference to me, but it certainly brings home the point that there are an especially large number of kids coming out of incarceration in this country. And I've seen different numbers, but certainly 100,000 a year is not an unreasonable number to be considering in the country. And that's my understanding of sort of longer term incarceration. When you include all kids that are in and out of detention, the numbers go up quite dramatically further from that. So this is a big, big issue. And re-entry is a huge problem. And of course, it's a huge just human problem, but if you look just narrowly at the issue of recidivism after incarceration, we know that what we're doing just is terrible, because we've got a 70% recidivism rate at 24 months or something on that scale. This is one study, this is one statistic, but the scale is unmistakably large, that incarceration is not an effective intervention. And actually there's a lot of research that I think supports the claim that incarceration, for the most part, actually just makes things worse. And that's a huge area of discussion. So I'll just leave it at that for now. But it's tragic. The other background issue is that the rates, and I'm sorry that this slide is hard to read, but the rates of mental health problems and substance use problems amongst incarcerated kids is extremely high. This is one study that, again, there are criticisms that can be leveled against this study. This is also a detention study, not a long-term incarceration study. Yeah, that'd be great. But it shows that the majority of kids in detention have at least a mental health disorder or a substance use disorder. Many have both, and many have quite substantial problems. And there's also good reason to believe that failure to attend to those problems is part of what contributes to the high recidivism rates and, unfortunately, re-incarceration. And this is a huge understatement, that integrated transition services are rare. I would say they're extraordinarily rare. They're extraordinarily rare. And even in Washington State, where we have FIT, there's only a very small percentage of kids leaving the system have access to an integrated transition service such as FIT. And another background piece is just that it's the degree to which families are left out of the reentry, reintegration process is really astounding. This is just one number, a couple of numbers, but it just illustrates that families, for the most part, are just not included in planning for reentry. And I think that that's part of, again, why things go so badly the vast majority of the time. And in many cases, kids are, all but just kind of left on the family's doorstep after incarceration. There are efforts in JJNRA, which are great efforts to try to improve family involvement. So I want to commend JJNRA for that. That's Juvenile Justice and Rehabilitation Administration, but certainly nationwide, huge problem. And this number, the fact that almost 70% of families report that they have trouble even getting their kids into a school. This is not academically successful. This is not in the right classes. This is just getting them into a school. Shows how difficult the problems are at reentry. This is just a quick list of some of the sort of common factors. I'm not going to, or elements. This is not a rigorously derived list, but just an impressionistic list of some of the things that are elements of successful interventions for justice-involved youth. And I put family-centered at the top of the list because that really does shake out as a huge, huge component. And to family programs that really do build capacity in the family for increased monitoring of the kids, but also support, warmth is also essential. Programs that really take substance abuse seriously and work on substance abuse. Programs that are very skills-based, and that would be sort of in comparison to something that's more insight-based, really it provides practical skills that can be kind of used in the here and now, have been shown to be typically most effective. Programs that draw upon intrinsic strengths that have been under-recognized or underutilized are typically most effective. Clinically informed is a bit more controversial, but some of the most effective programs do include some awareness of mental health diagnoses and how those should be addressed. And then that the typically effective programs are very individualized, not delivered in group format, although there are some valuable programs in group format, but they're individualized, they're really tailored to the strengths and needs of the particular youth and family. And doing all of that stuff at the same time is not easy. It requires a very intensive program, and that's what FIT has been designed to do, is to kind of do all of that stuff in the family setting, in the community setting, so in people's homes, if necessary, at court, at school meetings, to kind of try to do all that stuff very intensively to meet the needs, particularly of kids with co-occurring mental health and substance abuse problems who are being released from secure institutions. I think the program is probably very useful for kids who don't have co-occurring mental health and substance abuse problems as well. It's just that group is generally considered a kind of the highest need group, and so the program was designed particularly for them. I would describe the model as an ultra-intensive in terms of the amount of therapist or coach time allotted, and it's a phased integration of these different forms of pre-existing therapies or psychosocial interventions. And what I mean phased is that you do different things depending on where you are in the process of the therapy. When you start off, the child is actually still, the youth is still incarcerated. The family is engaged at that point, and the youth is engaged, and you have a sort of a set of tasks that's specific to that point when the youth has not yet returned to the community, and then your tasks are switched to a significant degree at the point of homecoming. So you adjust what you're doing to where the youth is in the process of going from incarceration to homecoming, and then ideally to long-term maintenance, sustainable maintenance in the community. And for those who don't know what MST is, of course, one could have a whole lecture on MST, but the nuts and bolts is that a highly trained and very closely supervised therapist meets very intensively with the family and youth in the home and community and helps them address very practically the most important environmental and individual factors that impact the youth's offending or risk of offending. The environmental is just a really key thing, since I think a lot of what community mental health, as I saw it, really attempts to solve very complex, socially complex problems through individual interventions, just with the youth, like psychotherapy with the individual youth. And I didn't see that being very impactful for this population, whereas MST and FIT, in turn, really tries to work on the broader, let's see, we'll stick with that, the broader system, so that you have the biggest chance of actually having the family make modifications in the overall environment that will support the youth's healthy adaptation and behavior. And the goals, they're pretty common sense. Lower the risk of reoffending, improve the family's ability to support and monitor, ideally achieve abstinence from drugs and alcohol, although FIT is not anti-harm reduction in any way. It recognizes that you want to be flexible to achieve your goals, but if possible, to aim for abstinence, improve mental health, increase healthy pro-social activities and peer connections, and improve educational and vocational engagement. And basically, FIT it's a toolkit that comes from all of these different forms of pre-existing psychotherapy, psychosocial interventions, which I have listed on this side, to try to address factors at all these different levels. And just because of time, we won't be able to sort of unpack this slide. It's obviously, there's a lot there, but I'm really hoping, and I'm confident that Nicole, FIT supervisor, when she comes up and talks about an individual case, she'll kind of talk about how this kind of works in action. I think that's easy. That's going to be more informative than kind of marching through the factors when you kind of really individualize it. I talked about the phases. These are the phases as they're described, and I think that's really important to think about this as a phased treatment. Referral and engagement is really, really key. And engagement is something that happens up front, but has to also keep happening all through the treatment, because these youth and families, to a very large degree, are not motivated in the way that we would hope they'd be, because in many cases, I think they've just been so beaten down by so many social factors and sense of failure and betrayal. And so helping to get them to see that there is the possibility that they could change in positive ways, feel like they have that capacity, and also understand the importance of change is a really big part of the work. You can have a huge toolkit, but the toolkit is irrelevant if you don't have motivation. So engagement throughout the whole process is essential. Maintenance is also really essential, and maintenance is about recognizing that even a fantastic FIT therapist, or we call them coach, is only there usually for 6 months at most. So we really want to to support the family to engage in interventions themselves that they're going to be able to sustain after the coach has exited the scene. And that's also very challenging and worthy of a whole hour or many hours of discussion. But I did just want to emphasize that it's something that we pay very close attention to, sustainability without our ongoing involvement. I've just listed some of the sort of the tools in the kit that some people may recognize from other therapies. Obviously, the fit therapists in the room know this stuff inside and out, but a lot of people recognize this from their work in doing other kinds of therapies. And it just shows that we do provide a kind of a menu of tools that are familiar and well-established, cognitive behavioral or motivational interviewing or DBT, dialectical behavioral therapy, psychotherapy tools to be used kind of judiciously, to kind of be individualized to the need of the individual youth and family. And I think that's a really essential piece, which is that you can have a whole bunch of tools and you can feel like you have like all these interventions, but you really have to think to make this the overall intervention work, you really have to develop shared goals with the youth and the family and surrounding systems, schools or parole counselors, the courts, shared goals that kind of everybody can sign on to. And then from that goal setting process, you then choose your tools. You don't just throw tools, don't just grab at tools willy-nilly. You really try to develop an integrated sense of purpose that is shared and that then is used to choose the interventions. And that's really essential to choose the right interventions, but also to prevent splitting or fragmentation of the teams. Because with these kids, there are inevitably crises, and crises make people very stressed out and very often lead to some kind of blame of one person to another on the team. And that's what I'm talking about as splitting. And then people start doing things at cross purposes, different people that are involved. And so kind of collective goal setting and returning to collective goal setting is absolutely essential for success. Just some of the nuts and bolts, and most people in the room know this, but this is sort of for those who don't and those who might be watching this at some point in the future. The caseloads are very small, 3 to 5 families per coach. The supervision is very intensive. And then there's supervision of the supervisor in the person of a consultant. The duration is usually about 6 months, starting 2 months prior to release. The intensity is high with meetings at least weekly and often twice weekly at the midpoint of treatment. And these are not just 45-minute sessions. These are often much longer, very intensive sessions. Sometimes they take place in schools, sometimes in homes, sometimes out in the community. The therapist is available 24/7 for crisis management and to help families apply the skills that they're learning in the moment. And there's a very high level of accountability in the form of adherence measures, which if people want to talk about further, we can. But I'll just keep moving for now because I think the other parts of the presentation are really valuable. There is evidence supporting the program's effectiveness. There's still room, of course, for more study, and there is further study underway. And if we have time, we might get an update on that from one of our expert audience members. But there's one controlled study, not a blinded study, but a controlled study that did show a significant reduction in felony recidivism. Again, we can talk about that further if that's of interest to the group, and I have the paper. We can talk about the methods if people would like to talk more about it. There's also been an independent cost-benefit analysis of the program done by the Washington State Institute of Public Policy, which comes out very favorably for the program, even though the upfront cost at almost $10,000 per participant looks very high. The savings in the end is very considerable. And the program has been recognized by many bodies that review such programs that we really rely on. And of course, the accolades are not the same as evidence, but it is an indication that the program has been recognized for its strengths. So just coming back, I just want to sort of coming back to my own story with this program. I've now been a supervisor in FIT for a number of months, and it's been very challenging work, because just because you have a great sounding program doesn't mean that you just kind of then check off a bunch of boxes and solve the problem for each kid. It's every family and every youth is different. The challenges are very intense. There are many disappointments as well as successes. But I must say that compared to my experience at a community mental health agency where I felt so ineffective, it's just been enormously gratifying to work with a program where I really see both impact and the promise of impact, even in the face of these challenges. So with that, I'd like to invite Nicole McManus up to talk a little bit about a case or two. She's a supervisor for the FIT team at Community Psychiatric Clinic, and I thought she could talk about a case or two that sort of illustrates in much more concrete terms how this all plays out.
Yeah.
Great.
Awesome.
And I'm going to pass you the mic, actually.
Oh, okay.
So if you just put this on your sweater.
Alrighty.
And then if you have a pocket, or you could hold it.
Okay. I'll just.
You don't need this, but I'll give it to you for when you're there.
All right. So, talking about a couple cases, I'm just a little background. I'm the FIT supervisor for CPC, and my team of therapists covers King and Snohomish counties in addition to Pierce and Kitsap. So therapists are going all over the western side of the state. So I could talk about really all the positive things about FIT and all the wonderful outcomes that we have, but I think the greatest thing about FIT is that we don't always see the benefits of all our hard work. Oftentimes we're just planting seeds for change. So with that being said, the first case that I want to talk about is a young man, 16 years old, who was diagnosed with ADHD and polysubstance dependence. He was charged for robbery, he had shot a victim, possession of drugs, and when we're working with these families, when we first start out, we come up with what's called overarching goals. And so for this youth, our overarching goals were refrain from substance use, participate in a pro-social activity, and attend school and pass classes. So pretty standard for most of our youth. This is a young man whose family comprised of his grandmother, and his mom is actively using meth and in and out of the home periodically. So our FIT coach, who is in this room, he had some wonderfully successful outcomes with this family. So starting prior to discharge, met with the youth in facility, out in the community. He engaged grandma and grandfather who had not a positive relationship. And so by working with grandma and with youth, got this kid to attend school regularly, improve relationship with his using mom. So by the end of services, this kid is no longer using meth, but in addition, having a positive relationship with his mom. When his mom is around, they're spending time together, having conversations, communicating. Part of keeping this youth safe was keeping him busy and finding what was considered a pro-social activity. And in our line of work, pro-social activity could take place in many different forms. It might not be your typical after-school basketball program, but in this young man's case, it was doing landscaping work with his grandfather after school, doing chores around the house, finding ways to keep him chopping wood, I think, was on the list as one of the activities that could take place if he was feeling that urge to use. So not only were we able to identify things not only was the coach able to identify things for this youth to be doing when he had the urge to use or to occupy his time, but collaborated with parole, collaborated with school, And now this youth is passing classes, attending school every day, and worked with grandma to the point of being able to provide verbal positive praise for this youth, because we identified that that was going to keep him motivated in the long run. And so now we're closing out services, and it's been a success by everyone else's eyes, in addition to our own, that he's achieving his overarching goals, and he's on track to continue to see improvement even after we discharge. So with every positive and like by the book, positive outcomes, right? Like this was the perfect case. I mean, we were even talking in consultation about, well, what was this kid doing that's he's been able to resist the urge to use despite his mom actively using in the home. I mean, this was a unique case in some respects, but also just very common of the positive outcomes that we see. But just like we have those by the book, best case scenario cases, we also have cases that by people who don't have the MST FIT background wouldn't be seen as a success. So this is another young lady that we're working with. We're actually closing out services here in the next couple weeks. She's 15 years old, diagnosed with PTSD and polysubstance dependence. She was arrested for burglary, assault, and possession of weapon. And with this young youth, our overarching goals were that she was going to refrain from substance use, meth in this case. She'd be curfew adherent. This youth had a long history of AWOL, in and out of the home for a long period of time, attend classes regularly, and with passing grades. So in this particular case, the family was set up by the caregiver, her mom, and she also had a sister that was in and out of the home a lot, with 2 nephews that were in and out of the home. But it was just mom and daughter. And then her dad the family was separated, but her dad would participate in sessions periodically. So, like I said, with MST FIT, we are planting seeds for change, and this is a perfect example of that case. She has been AWOL and in and out of the home. We've had some successes as far as being home for an extended period of time. So I think it was in mid-October, she was AWOL, and she was gone, and we weren't sure where she was going. Our FIT coach was in contact with parole, working with mom and with dad on what we can do to bring this kid in. And that was, so we do, with MST FIT, we do FITs on behaviors. And so we're looking at all the contributing factors to that specific behavior and what we can do to address it. So we were doing AWOL FITs, and we were looking at what we can do to target that behavior. So it was reaching out to peers, reaching out to the school, figuring out what we can do to encourage this youth to come home. Turns out she was picked up by the police, and she was sent back to one of the facilities for a short period of time, and then she was re-entered back into the home. And during that time, our FIT coach was working in facilities and with parole and with the family to come up with a comprehensive plan for when she was released back out. So when she came back out of the facility, which was mid-November, we set up rewards and consequences for in the event that she were to leave. We were able to engage mom on how to create a clear and concise supervision and monitoring plan despite her working schedule, despite her sense of hopelessness of her kid being in and out of facility, even though she was part of the FIT program, and the arrests. And then also there was a level of gang involvement and possible drug dealing that we were also having to work with police hand in hand to address. So our FIT coach was going into the home 2-3 times a week, working with mom on really building up her skills of how are we not only going to implement consequences in the event that she is not curfew adherent or leaves again, how are we going to ensure that she gets to school every day, because that's just another level or avenue of supervision, and what are we going to do to keep her motivated from reaching out to these what we would call negative peers. And so by improving and building up on mom's skill, we were able to, she removed the use of the youth's cell phone because that was her access to negative peers. She was no longer, she didn't have any access to the computer, which was Facebook, the other avenue of reaching out to peers. We were also looking at phone check-ins during the afternoons and ways to keep her busy in the home and what she was going to do to occupy her time, other avenues of pro-social activities at school, and what we can and who we're going to reach out to in the community in the event that maybe she didn't get on the bus to get home that day. And so that was, or maybe who her peers were, so that if mom couldn't get a hold of her daughter, she had the number of the boyfriend or the friend down the street. And with all that being said, with all these things put in place so that she was staying home and coming home and not using, we were able to keep her home for 5 weeks. And in our line of work, that is a huge success. So 5 weeks of the youth staying home, and then when things are good, things are really good. And so oftentimes with our families, they see some small success and they're like, okay, well, then maybe I don't need to be doing this anymore. They tend to kind of fall back into old patterns and behaviors. And with behavior change, we know it takes time and nothing happens overnight. And oftentimes things have to get worse before they get better. You take a few steps forward just to fall a few steps back. And this is that perfect example. She missed curfew and was AWOL for a day, came home, and then was AWOL again and was gone for 2 weeks before she was picked up by the police and now is incarcerated for the next 30 days. So needless to say, we're unfortunately having to close out of services, but at the end of the day, as we're closing out services and working with mom around maintenance planning and what she can do when this youth returns back into the community, we have clear evidence of success. Those 5 weeks when she was staying home, going to school, not using, engaging with positive peers. She was attending, I believe she was attending NA meetings with her sister. By capitalizing on those 5 weeks, we know that mom is not only capable of change, but so is the youth. And that's the success in our book. A lot of the times, like I said before, we're not ending on sessions like that young gentleman who is doing all these great things and scoring 10 on his overarching goals. Oftentimes, we're not seeing the benefits of our hard work. We're only able to demonstrate evidence that it's there and that there's continued success moving forward. So that's just a brief synopsis of what our cases tend to look like. But yeah, so I'll send it back to you.
That's great. Thank you.
Yeah.
And then, Jake, why don't you suit up while I introduce you, or mic up. So Jake Towle is next going to speak to us. And Jake is, sorry to look away, but I'm going to get his presentation going. Jake is the Mental Health Programs Administrator for Juvenile Justice and Rehabilitation Administration in Washington State. And he's going to put FIT in context in terms of what kinds of services, where it fits in the ecosystem of services for youth leaving incarceration in Washington State. Thank you, Jake.
Great, thanks, Nick. Well, good afternoon, everybody. Little background about me. Been working with incarcerated juvenile high-risk offenders for 22 years now. Started out as a kind of part-time counselor at a large institution and kind of worked my way up to kind of middle management, up to administration. I've been a program manager of several different living residential units within our JRA system. My background is in psychology and education, so my focus really more lean towards our youth that have significant mental health issues. And in my 22 years of working with our youth at JRA, we've seen, while there's been a decrease in our population, there's been a pretty overwhelming increase of youth that have have co-occurring disorders, but more specifically, many more kids coming through our system that have mental health concerns and issues, and definitely diagnosis, as we've seen very recently. So I want to talk to just kind of in the context of JRA. All of our youth that we refer to CPC and Central Washington Community Mental Health, our two FIT providers, kind of all funnel through my office. So I generate a list of youth, and sometimes it's really tough to get, as we've seen, trying to fill caseloads for these folks is sometimes difficult to get the co-occurring disorder piece nailed down, because the reason for that, I would love to have every kid in JRA have FIT services, because I think it would be so impactful and so wonderful. And Nicole talked about not sometimes knowing the outcomes, but I see it every day because we get contacts from our former juvenile offenders that just rave about FIT. They rave about the FIT coaches and the programs. And more often than not, those are the kids we don't see back. Those are the kids that we get phone calls from that are successful. They're going to college, they're finishing high school, they got a great job, they got married, they're having a kid, that kind of stuff. But because the program is an evidence-based program, which means our Washington State Legislature funds the program, I have to look at the very specific eligibility requirements for the youth in JRA to get into the program. So often I'm saying, okay, I've got a kid here who's got lots of mental health programs, but his substance abuse has a history of it, but no diagnosis, or he hasn't had evaluation for 2 years. So I really have to look at that population, and it's a bit of a job for me sometimes, because then I have to contact people that do those evaluations, because it might be the flip side. I got a kid who's got, wow, he's doing meth and all these different drugs and alcohol and all these things, long history of it. He looks like he's got some pretty significant PTSD or ADHD or what have you, but there's no current diagnosis. He needs to be seen by a psychiatrist. You say, can this kid be seen by a psychiatrist? Great, we'll get him on the list. 6 months later, okay, we can see him, but now he's being released. So that's kind of an extreme. It's usually quicker than that. But some of our kids come through and they've got anywhere from 30-day sentence up to 7 years. I've had youth come through our system that have been charged with murder, murder one, and they spend time with us before they go on to the adult system. But we definitely work with those kids, whether they're leaving us or going on to the adult system. So it's a bit of a tug sometimes, but it's getting better. We're getting a lot more feedback from, as people get to know more about FIT and what the program is and the successes we're seeing a lot more folks coming through and wanting to, I want to get my kid into FIT. What can we do, or what do we need to do to get my youth into FIT? So that kind of a little background, but I'll zip through just kind of some detail here. Historically, behavioral health services of juveniles have been fragmented, inefficient, and disconnected, kind of what Nick was talking about, and there's still some of that to a degree in our system. It's getting better, but the services have been individualized and encompass all aspects of youth life to ensure successful reentry into the community. So in JRA right now, we're really working on transition services. A lot of the stuff that we're trying to expand on, FIT already does. It's that community outreach, it's the youth-centered, family-centered approach, and we wrap the services around that youth. We're really looking at that, and like in the second paragraph here, is based on the strong continuity of care. We had a meeting yesterday actually, that Dr. Lee was at and Nick was at, that we kind of talked about that. There are a lot of our youth that are coming through our system. They come through and they get these great services within juvenile justice now. Or it used to be that way, but they're getting a lot better services these days. They get fit services. That continuity of care is sometimes, and it used to be, Nick was kind of alluded to this as well. I had experience when I first started 22 years ago as a frontline counselor working with the youth, and I'd worked really hard with this youth and we had some good success. We got him turned things around. He was committed to not using drugs. He was committed to getting a job, finishing his education. He actually got his high school diploma while he was with us in JRA. But he was a DCFS youth. So he was a state award of the state. So I brought him up to the Seattle office, and we sat down and met with his caseworker, and his caseworker said, well, you got two choices. I can give you a bus ticket and you're on your way, good luck, or you can sit around here and it might take us 6 hours, but we'll try to find a placement for you. So what do you want to do? Kid says he's 17 years old, bus ticket please, and off he went to go hang out with his friends. Don't know what happened to that youth. There was never that much follow-up back then. It's much better now. We work with the counselors, we work with the caseworkers, the fit coaches. We definitely work very hand in hand with the community partners. But it's gotten a lot better. We do a lot of transition now. A lot of our focus in JRA is transition, and fit is a huge part of that. Like I said before, if we could get fit for all of our youth, we'd have a lot more success and a lot more less recidivism. You guys all know this, but this is kind of how we define co-occurring disorders in the state system. Co-occurring substance-related and mental health disorders have one or more substance-related disorders as well as one or more mental health disorders. And that's sometimes it's prescribed. The way I have to look at it in terms of referral, okay, this kid has to have an assessment and has to have a substance abuse where it meets certain level of diagnosis, and then a DSM diagnosis. We've got it, and we see a lot of kids that come through. It's like, well, they're kind of on the edge, and I'd love to get those kids in. Sometimes we have to work harder and get that done, but often there's kids that fall through the cracks and don't get fit services because we can't get those two together. Within our system now, our transition services begin when the youth first comes to us. We start looking at, okay, where are you going to be placed? What are the treatment plans? What's your education plans? What's your vocational plans? They get assessments. We have our integrated treatment assessment, our individual client or initial client information, which are really great little assessments and screens that are done so that we can get a snapshot of the youth as they're coming through, and that is used as a foundation to develop treatment throughout their stay with us. I won't read this to you, but you guys are well aware some of the most common psychiatric disorders seen in patients with co-occurring addiction issues include all of these. We see a lot of this with our youth right now. Much more prevalent than it was 10 or even 15 years ago. A lot of the kids I dealt with when we first started working at JRA, they were all kids that were heavily involved in gangs. So it was a lot of crime related to that, violence and theft and that kind of thing. More and more these days, it's much more, we're seeing it's more property crimes, it's more the lesser violent things, but the kids are much more in need of services. Another kind of quick list. A lot of our mental health kids, they try to compensate for their mental health and not having the right medication by using substances. I won't read this for you either, but our assessment process, a lot of it is kind of based on what FIT is. It's engaging the client, engaging the family, screening to identify COD, determine the severity of our mental health substance use disorders. So a lot of our youth are, like talked about before, they're on the waiting list, and it's gotten them a lot better. We have psychiatrists as well. Dr. Lee and Dr. Weiss, Nick, work at one of our at Echo Glen Children's Center, and they work with our youth directly as psychiatrists. But we have psychologists also that are full-time at our institutions, and they really help determine what the needs are for our youth. And it really does help, and it really helps develop that treatment plan that we're working with the youth, again, youth-centered, family-centered. Okay, what do we need to do to really help this youth and his family or her family to be successful? Just some kind of statistics here. National prevalence of COD is as high as 66%, with 95% experiencing functional impairment. So there's a great need for programs like FIT. In Washington State, it's 68% right now. Challenges for our youth. We have as Nick and Nicole also talked about, a lot of our youth it's really a struggle for them to get back into their communities. Nick talked about the schools. We see that all the time, where the youth and the family are not only working with a FIT coach, and that really helps that out to get them back into school, but imagine a single mom who's trying to work full-time and raise not only the teenager that's coming back, but 3 of his or her siblings, and then trying to get back their 16 or 17-year-old back into school, and the school says, no, we've decided we don't want Johnny back at the school. So we're going to give you a referral to an alternative school. And then the alternative school is full, or what have you. So it is really a struggle for our youth to get back into educational and vocational programs. And that's really something that is really a foundation for these kids being successful. You just send them out like we used to and say, good luck, they'd come right back. You know, in certain terms of recidivism, I've seen kids come back 2 days later. They get released, they get out, you got a plan or lack thereof, and then you get a call from the courts and say, Johnny's back, he'll be at your doorstep on Friday. Good luck, he's got 5 years this time instead of 16 months that he was last time. But I've also seen kids that have been released from JRA more recently than not that come back and they don't come back. And those are the guys that get phone calls. I'm going to college, I've got a family, I've got a good job, that kind of stuff. So some of the things that's happening are making us successful. 65% of our youth meet currently in our population, 65% of our youth, our mental health target population, DSM diagnosis, psychotropic meds, and or self-harm is what we look at. 67% of the youth are diagnosed with substance abuse disorder. Just a quick list of some of the evidence-based programs. Along with FIT, we've got our Matrix substance abuse model. It's an evidence-based substance abuse treatment model. I've got FIT there twice, but it's because it's so good. But, we've also got the adolescent community reinforcement approach, which is kind of the community side of the Matrix model, the ACRA. Dialectical behavior therapy that Nick talked about. We also have our aggression replacement training, ART. I'm proud to say I've been doing aggression replacement training for 10 years, and I'm a master trainer. I think it's a very effective, it's It's much more of a skill-based program, if people are familiar with ART, more than versus a therapy. But it really does teach our kids, like the title says, replacement skills and behaviors to violence and aggression. Right now we have been awarded a grant to do our Bridge to Recovery program, funded through OJJDP. It's a small 2-year program. This is very much like the FIT program, and our FIT coaches have been great working hand in hand with our BTR youth, often our BTR youth that get our chemical dependency and mental health treatment in the institutions, then transfer and become FIT youth. And I think that's a great kind of hand-in-hand thing. Just some kind of quick transition stuff that we look at when we're from the get-go, when the youth comes to us, and as throughout their continuum of care with us on into parole. There's a large percentage of our youth, unfortunately, get released, and they have no supervision at all in terms of the state. They have no parole services. They're released to family. A great thing about FIT, if a youth comes through and they become FIT eligible, I assign them FIT parole. So they'll get 20 weeks of parole as well as the FIT services. But about probably 40% of our youth go out and are released with no supervision beyond just their parents or guardians. But we look at the substance abuse, mental health services, healthcare. We're working pretty closely with the Healthcare Authority and Economic Services Administration, ESA, to develop better cross-system agreements. But we look at education, Medicaid, insurance, social services, job finding and training, housing assistant, and we're working with the state's mental health program, Children's Mental Health, on their system of care. That involves our statewide family youth system partner roundtables, the FISPERTs. They're local, regional, and statewide bodies that work not only with the youth and families, but the communities that support the youth and family, along with peer support, and the program they're implementing right now is Wraparound with Intensive Services, or Weiss. We've talked about this kind of already, and it's been alluded to before, but it's really looking at what's going to be most helpful for our youth, what's going to be most helpful for our youth and their family, and it really kind of boils down to they've got to be able to have a voice at the table. It used to be, okay, we've got this treatment plan, we've got this transition plan. Case manager would write it up. I was guilty of it as a counselor and case manager. I'd write it all up and say, okay, Johnny, here's your treatment plan, here's your transition plan. No input from them ahead of time. It was just my plan that I thought, well, this will work best, best intentions, best for this youth. Much more now, it's okay, Frankie, Joey, whoever you are, what do you want? What's your focus? What would you like to do? And then bring in the family. Okay, what's going to be helpful for you, mom or dad or grandma or uncle or aunt? How can we make not only Johnny be successful, but as a family, you successful while they're here and when they are released? Good question?
Well, I wondered actually, Jake, that was a really nice point that you just made about how your services are evolving, how your philosophy is evolving. And I thought it actually might be a nice point to transition to just a little bit of time for questions.
Sure, yeah, I know we're kind of running out of time here.
5 minutes left, and that would
certainly.
I thought that might be a good inflection point if you're okay with that.
You bet. I mean, you guys will get a copy of this, but theory or practice, kind of it's a little more detail about what we do in JRA. We've developed these reentry team meetings, which we used to call and still combo with our multidisciplinary meetings that the coaches are invited to. And just kind of in closing the statements there, but thanks for your time. And yeah, if you have any, let's allow for a little time for questions. Sure.
So maybe we could all stand up. And I'd actually like to invite Josh. Well, you know what? Maybe we'll actually leave you guys there because there's so many people in the room with expertise in this, not in general, but also in this model, that I don't want to just kind of bring up the leaders of the program. So I think everybody has a lot to offer. But I did want to at least have a couple of minutes where people could ask questions or make comments or voice concerns, because there's a lot in this presentation which is very exciting to me. I think there's also a lot in everything that we have talked about that is understandably the source of mixed feelings among some people and controversy. This approach, which I have a lot of confidence in, is it's a particular approach, and it doesn't do everything. And I was actually thinking as Jake was talking that when Jake talked about the value of parole and how it's disappointing that not all families have parole services, and I very much understand Jake's perspective, and in a lot of ways I share it. But there may be people who, and there are some families who see it differently and who say, well, actually, youth will say, well, I'd rather not be on parole. I'd rather not have that. So just wanted to kind of make that point. I also wanted to emphasize that some of the things that we missed, or not missed, but that we didn't have time to address, and that's the racial and ethnic issues as relates to FIT are very important. So I wanted to give a chance for the group to ask questions about that or make comments about that if they felt that that was something on their mind that they wished that we had talked about. Sue?
I wanted to thank you both for coming up, in addition to Nick, for your presentation. And I'm curious, both from an administrative perspective and from a supervisor perspective, if you could have like 5 years from now, what would be on your wish list for things to change, or have the program be better in any way, or I know kind of being on the ground, you've probably given that a lot of thought, or
In terms of the FIT program itself?
well, I mean, from an administrative standpoint, I'd actually just be curious about transition services more in general, and then I'd also love to hear about FIT in particular.
Yeah, I mean, like I talked about, we've had quite a push lately. It's been the last 2 years. We've actually developed a transition services kind of department within our department to deal with this kind of issues, because there's such a strong prevalence of across the nation of reentry and transition for not only juvenile offenders but adult offenders, people coming back into the community. So it's been a big push for us, and it's grown, but it's been really difficult. It's because there's so much within the state government. There's so much bureaucratic kind of red tape, and who's going to pay for that? Who's going to buy this? And who's got the funding? And sorry, the governor says we don't have the budget for that anymore. Kind of issues. If I had a wish list, it would be that we had a FIT service program in each county. I think that would be fantastic, just because it's such a great program, and it really impacts our kids. And it on the flip side, it impacts the staff that work with the FIT providers, the FIT coaches. I just hear raves about the FIT program and the FIT coaches that work with our kids, from the institution staff. We also have our community facility, our group home staff. When they see a kid that's been assigned to FIT, they send me a huge email and say, thanks, Jake, because they know that they're going to get that extra help, not only extra help for transition services, but they know, oh good, this kid's going to have a chance to not come back. And then in terms of the administrative side, it would be just wonderful too if there was a way to not only continue to fund this at a larger level, but just get those legislators over there to say, okay, you're right, this is such a great program, and make it easy. Every year it's a push, it's a struggle to keep fit, not only fit, but the other evidence-based programs we've got just afloat sometimes.
Yeah, well, I mean, just to add on to that, I think, in the next 5 years would be really great to see is, we're a small program. I mean, we're covering 4 counties between 5 therapists. That's a lot of ground to cover. And, I mean, when you look at, even though we have small caseloads, I mean, they're traveling wide distances to get to these families. And so whether it's, team in every county or just, more, smaller groups smaller teams that are able to, smaller catchment areas, that would be really great to see. And also just, between institutions, I mean, we're collaborating with a lot of different people and in, figuring out some sort of way of like standardization as far as, like in the meeting we were at yesterday, figuring out how youth are referred to the program and how the transition can look back into the community and between facilities and with parole. Our coaches work really hard to make sure that we're working hand in hand with parole because it is so important to the youth and to the success of the families, and finding ways to standardize some of that.
I'm aware of the time, and as somebody who was trained in psychodynamic psychotherapy, I'm kind of a stickler for endpoints. So unless somebody else has a burning question, I think we'll end there. And I would encourage you guys to get in touch with, if you have more questions or comments, suggestions. Does that sound all right? Any burning questions? No? All right. Thank you guys so much for joining us.